Hello, and welcome to your ultimate guide for your CPT exam. My goal today is to give you everything that you need to understand the full concepts, master them, and walk you through the CPT exam with total confidence. In this video, we will cover federal safety agencies, accreditation standards, ethics and HIPAA, bloodborne pathogens, quality control response.
With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt.
And remember, our website helps you to practice your exam with our practice questions, timed mock exams, and study guides. You will find the link in the description below. Let's get started. Welcome to your comprehensive guide for mastering safety and compliance on your certified phlebotomy technician exam. Today, we cover everything you need to confidently tackle Domain 1, including federal safety agencies, accreditation standards, ethics and HIPAA, quality control, the bloodborne pathogen standard, sharps disposal, biohazard spills, and exposure response. By the end, you will be ready to pass. Domain 1 accounts for roughly 14 to 16% of your exam, making it one of the most heavily weighted areas you will face. Every concept here protects real patients and real workers in real laboratories every day. So let us not waste any time. Let us dive into the federal framework that shapes what a phlebotomist does at the chair. Before we dive into our first topic, I want to let you know about something incredibly valuable for your exam preparation. I have created over 300 completely free practice questions that work hand in hand with everything we are covering today. You will find the link in the description, and I really encourage you to bookmark it now. Let us start with the most powerful agency in your daily life as a phlebotomist, the Occupational Safety and Health Administration, called OSHA. OSHA was created by the Occupational Safety and Health Act of 1970 and lives inside the Department of Labor. Its job is to write and enforce the workplace safety rules that protect every healthcare worker. Here is what makes OSHA so important for the exam. OSHA is the only one of the three federal players with actual enforcement power. They can show up at your workplace without notice, conduct an inspection, and issue citations and fines. Remember this clearly. When penalties happen, the employer pays them, not the employee. Employees have rights, employers have obligations. OSHA standards relevant to the laboratory live in Title 29 of the Code of Federal Regulations, Part 1910. The big ones to know are the Bloodborne Pathogens Standard, the Hazard Communication Standard, the Personal Protective Equipment Standards, and the Laboratory Standard for Hazardous Chemicals. Each of these creates very specific employer duties that we will touch on today. The Hazard Communication Standard is also known as the Right to Know law. It requires every workplace to label chemical containers, maintain a safety data sheet, and train workers on chemical hazards. The Safety Data Sheet, abbreviated SES, replaced the older Material Safety Data Sheet and follows a strict 16-section format. Sections 1 through 8 are the most heavily enforced. Next, we have the National Institute for Occupational Safety and Health, known as NIOSH. Here's the trap that catches many students. NIOSH lives inside the Centers for Disease Control, not OSHA, and NIOSH does not enforce anything. NIOSH conducts research, makes recommendations, and certifies respirators like the N95. So remember, NIOSH-certified, but OSHA-required. The third agency is the Centers for Disease Control and Prevention, headquartered in Atlanta. The CDC writes guidelines rather than enforceable laws, but its guidelines are so authoritative that accreditation bodies, and even OSHA itself, adopt them by reference. The CDC gave us Standard Precautions, the categories of transmission-based precautions, hand hygiene guidelines, and the 4 Biosafety Levels. Let me give you a concrete example of how the Biosafety Levels work. When you spin a tube of patient blood for routine chemistry testing, you are working at Biosafety Level 2, because every specimen could carry hepatitis B, hepatitis C, or HIV. Routine teaching organisms sit at level 1, while highly infectious agents like Ebola sit at level 4. Here is a memory aid for test day. Think of OSHA as the police officer with a ticket book, NIOSH as the scientist in the laboratory writing reports, and CDC as the public health doctor publishing recommendations. Only the police officer can hand you a fine. The other two advise and inform but cannot enforce. On your exam, expect questions that test whether you can assign a function to the correct agency. Hazard communication container labeling is OSHA. Respirator certification is NIOSH. Standard Precautions guidelines are CDC. If a question mentions a fine or a citation, the answer is almost always OSHA. Lock that pattern firmly into your memory. A common pitfall is mixing up NIOSH and OSHA when discussing personal protective equipment. NIOSH certifies the N95 respirator itself, putting that little stamp of approval on the device. But OSHA is the agency that requires your employer to provide the respirator, train you to use it, and fit test you annually. What we just covered is exactly the type of material you will find in our free practice question bank. These are not just basic recall questions either. They are carefully designed to test your deep understanding of agency roles and exam-style traps, just like the real NHA exam will. Grab them from the description below. Now let us talk about the operational standards that shape how laboratories run. The Joint Commission, abbreviated TJC, is an independent nonprofit founded in 1951. It accredits more than 22,000 healthcare organizations, and its accreditation is functionally mandatory because Medicare accepts it as deemed status, allowing accredited facilities to bill federal programs. The most heavily tested concept from the Joint Commission is the National Patient Safety Goals. The top goal for a phlebotomist is goal number 1, which requires you to use at least 2 patient identifiers before any blood draw. Acceptable identifiers include the full legal name, date of birth, and medical record number. Room number and bed assignment are never acceptable. Next is the Clinical and Laboratory Standards Institute, known as CLAC. CLAC does not inspect anything. It writes the technical consensus documents that everyone else cites as their authority. Your employer's standard operating procedure for venipuncture was almost certainly written with CLAC document, GP41, open on the desk. Memorize that GP41 governs diagnostic venous blood collection. To remember the CLAC documents, think GP for general phlebotomy. GP41 covers venipuncture. GP42 covers capillary collection, dialysis. GP43 covers coagulation, specimen handling, (DI). And GP44 covers general specimen processing. The older H series numbers were retired and renumbered into the GP series, which often shows up on exam questions as a deliberately confusing distractor. The third operational body is the College of American Pathologists, known as CAP.I. CAP runs a laboratory accreditation program with rigorous discipline-specific checklists. CAP also operates the largest proficiency testing program in the world, mailing unknown specimens to laboratories for blinded analysis. CAP inspections happen every 2 years using a peer review approach where laboratories inspect each other. Now, let us pivot to ethics, because the NHA exam loves ethics questions. The 4 classical principles of healthcare ethics are autonomy, the patient's right to choose, beneficence, acting in their best interest, non-maleficence, doing no harm, and justice, fair treatment regardless of background. Every tenet in the NHA Code of Ethics traces back to these 4 principles. The NHA Code of Ethics has 10 tenets, but a few stand out for testing. Maintain strict confidentiality of patient information. Perform only services for which you are qualified. Take action to oppose and report dishonest or illegal acts. Respect the rights of patients and colleagues regardless of background. And comply with all federal, state, and local laws. This brings us directly to HIPAA, the Health Insurance Portability and Accountability Act of 1996. HIPAA created the federal privacy regime for protected health information, called PHI. There are 18 specific HIPAA identifiers, including name, address, dates, phone, email, social security number, and medical record number. Civil penalties reach the millions, and criminal cases can mean prison. Here is a high-yield exam pattern for HIPAA. Discussing a patient with another caregiver who is not involved in that patient's care is a violation. Leaving a requisition slip face up on an unattended cart is a violation. Even whispering about a patient in a public hallway is a violation. The safest answer is always the most cautious one. Scope of practice is another easy exam point. A CPT may collect venous and capillary specimens, prepare them for transport, perform CLIA-waived testing, and reassure the patient. A CPT may not interpret laboratory results for the patient, recommend treatment, or perform arterial sticks unless specifically credentialed. Stay in your lane, and the law will protect you. I know we are covering lots of detailed information, and you might be wondering how to practice applying all these concepts. That is precisely why I put together those free practice questions I mentioned earlier. They help you work through realistic scenarios that combine multiple concepts, exactly the way the NHA exam will challenge you on test day. Now, let us tackle quality control and quality assurance, two terms students constantly mix up. Quality control measures whether a single instrument is producing accurate results today using control materials. Quality assurance is the broader system that includes quality control plus pre-analytic and post-analytic monitoring, proficiency testing, and continuous improvement. So quality control is daily and narrow, while quality assurance is global. Laboratory testing happens in 3 phases. The pre-analytical phase covers patient identification, ordering, collection, transport, and processing. The analytical phase is the actual measurement on the instrument. The post-analytical phase is reporting and clinical action. Here is a heavily tested fact. Roughly 60 to 70% of all laboratory errors happen in the pre-analytical phase. Quality control results are tracked on a Levy-Jennings chart, which plots daily control values against time. The chart shows the mean as a center line and standard deviation lines at 1, 2, and 3 standard deviations above and below. In a normal distribution, 68% of values fall within 1 standard deviation, 95% within 2, and almost all within 3. On top of the Levy-Jennings chart, we apply the Westgard rules, a multi-rule procedure that detects both random and systematic errors. The 1-2S rule fires when a single value crosses 2 standard deviations. But here is the critical exam point. The 1-2S rule is a warning only. It is not a rejection rule. It just signals to investigate. Now, the rejection rules are different. The 1-3S rule fires when one value exceeds 3 standard deviations, indicating random error. The 2-2S rule fires when 2 consecutive values cross 2 standard deviations on the same side, indicating systematic error. The R4S rule fires when the spread between 2 consecutive controls exceeds 4 standard deviations. Each one means stop. Here is a memory aid for Westgard. Think of 1-2S as a yellow caution light. Slow down and look around, but you can keep going. Think of 1-3S, 2-2S, R4S, 4-1S, and 10X as red lights. You must stop and fix the problem before you proceed. Yellow warns. Red rejects. Quality control connects directly to CLIA, the Clinical Laboratory Improvement Amendments of 1988, (DITA). CLIA federally regulates every site that tests human specimens for diagnosis, prevention, or treatment, no matter where the testing happens. There are 5 types of CLIA certificate, but the one phlebotomists encounter most is the Certificate of Waiver, covering simple, low-risk tests. Common CLIA-waived tests include urine dipstick, fecal occult blood, whole blood glucose by approved meter, urine pregnancy testing, rapid strep, rapid influenza, point-of-care prothrombin time, and hemoglobin A1C by approved cartridge analyzers. The defining feature of a waived test is simplicity, low risk of error, and a failure mode that is obvious if it occurs. Here is an absolutely critical exam point about CLIA-waived testing. The moment you deviate from the manufacturer's instructions, even slightly, the test is reclassified as high complexity. That includes using expired strips, skipping quality control, or substituting a different control material. Follow the package insert exactly, every single time, no matter how rushed your shift becomes. A common student mistake is reporting patient results from an out-of-control run, hoping the corrective action later will fix everything. That is exactly backwards. When a run is out of control, you stop reporting, troubleshoot, document the failure, take corrective action, and verify that controls have returned to acceptable limits before you release any further patient results. If some of these more advanced concepts feel challenging right now, do not worry at all. That is completely normal, and it is exactly why I created that comprehensive practice question bank. Working through those problems will help solidify your understanding, build your confidence, and turn these abstract rules into real exam-ready skills you can rely on. Now we move to the heart of phlebotomy safety, the bloodborne pathogens standard, codified at 29 CFR 19-10.1.030. This standard was first published in 1991 in response to the HIV epidemic and was amended by the Needlestick Safety and Prevention Act of 2000. Every word exists to keep healthcare workers safe. The standard applies to any worker with reasonably anticipated exposure to blood or other potentially infectious materials, abbreviated OPIM.I. OPIM includes semen, vaginal secretions, cerebrospinal fluid, synovial, pleural, pericardial, peritoneal, and amniotic fluids, saliva in dental procedures, and any body fluid visibly contaminated with blood. If you cannot tell what a fluid is, treat it as OPIM. Every employer must produce a written exposure control plan that identifies covered job classifications, documents methods of compliance, schedules the hepatitis B vaccine, sets up post-exposure follow-up, communicates hazards through training, and maintains records. The plan must be reviewed and updated at least annually. New technology that reduces exposure must be evaluated and considered every year. The bloodborne pathogen standard imposes a strict hierarchy of controls. First, eliminate the hazard. Second, use engineering controls like self-sheathing safety needles. Third, apply work practice controls like never recapping needles. Fourth, use administrative controls like training and scheduling. Fifth and last, use personal protective equipment. PPE is the last line of defense, never the first line. The hepatitis B vaccine series must be offered free of charge to every covered employee within 10 working days of initial assignment. The employee may decline, but must sign a specific declination statement whose exact wording lies in Appendix A of the standard. An employee who declines may always change their mind and request the vaccine later, free. Sharps disposal is governed by the same standard at subsection D file. Contaminated sharps must go into containers that are closable, puncture-resistant, leak-proof on the sides and bottom, labeled with the biohazard symbol or color-coded red, and maintained upright throughout use. The fill line is at approximately 2/3 to 3/4 full. Overfilling has caused fatal needlesticks to housekeeping staff. The single most tested rule about contaminated needles is the prohibition on two-handed recapping. Two-handed recapping is forbidden by federal law. The only legal exception is a one-handed scoop technique or a mechanical device, used only when no alternative is feasible. In modern practice with safety-engineered needles, you should essentially never need to recap a contaminated needle. Employers with more than 10 employees must maintain a Sharps injury log that records the type and brand of device involved, the department where the incident happened, and an explanation of how it occurred. The log must be maintained for 5 years and must protect employee identity, with names redacted in any version that becomes publicly available. To remember the Sharps container requirements, use the phrase closable, puncture-resistant, leak-proof, labeled, and upright. Some students prefer the acronym CPLU. Picture a red rigid container with the universal biohazard symbol, sitting at chair height, never overfilled, never moved while open. Activate the safety device, drop the needle in point first, and walk away. A common pitfall on the exam is the answer choice that suggests setting a contaminated needle on the tray for later disposal. That is never correct. The needle must go directly from the patient's arm into the Sharps container at the point of use, with no detour through the tray, the cart, or your pocket along the way. Remember that mastering these concepts takes practice and application. The free practice questions in the description are designed specifically to help you take what you are learning here and turn it into exam-ready skills. They include realistic scenario-based items on bloodborne pathogens, sharps disposal, and exposure control, exactly the way the NHA tests it on the real exam. Now, let us talk about regulated medical waste and biohazard spills. Regulated waste includes liquid or semi-liquid blood, items that would release blood if compressed, items caked with dried blood, contaminated sharps, and pathological waste containing blood. All of this material must go into containers color-coded red or labeled with the biohazard symbol on a fluorescent orange background. For a blood spill on a hard surface, the CDC recommended sequence is straightforward. First, put on your gloves and any other personal protective equipment. Second, absorb the spill with paper towels or absorbent granules. Third, clean the area with detergent and water to remove organic matter. Fourth, apply an EPA-registered hospital disinfectant or freshly prepared bleach. That 1 to 10 dilution is one of the most heavily tested numerical facts on this exam. 1 part bleach to 9 parts water gives you 10 parts of working solution, with about 5,250 parts per million of available chlorine. Bleach loses chlorine over time, so prepare the dilution fresh daily. To remember the spill response, think cover, clean, contact, contain, dye. Cover the spill with absorbent material, clean away organic matter, allow the disinfectant the manufacturer-specified contact time, and then contain the contaminated waste in a biohazard bag. Skip any of those 4 steps and the disinfection fails, no matter how much bleach you used on the surface. Eye wash stations are governed by the consensus standard ANSI Z358.1. The station must be within 10 seconds of travel time from any hazard, deliver at least 0.4 gallons per minute for 15 minutes. Run at tepid water between 60 and 100 degrees Fahrenheit and activate in 1 second or less. During an eye splash, the worker holds the lids open and rolls the eyes in all directions for the full 15 minutes. Cutting the flush short is a common real-world error and an easy exam trap. After the flush, medical evaluation is mandatory, no exceptions, no shortcuts, no toughing it out and going home. If you sustain a needle stick, the protocol is non-negotiable. First, remove the contaminated sharp safely. Second, wash the wound with soap and water for at least 30 seconds. Do not squeeze or milk the wound. That increases tissue trauma and is not evidence-based. Third, flush mucous membranes with copious water if exposure was to eyes, nose, or mouth. After reporting, the source patient is evaluated for hepatitis B, hepatitis C, and HIV with appropriate consent. The exposed worker is offered baseline and follow-up testing. Post-exposure prophylaxis for HIV should ideally begin within 1 to 2 hours of exposure. For hepatitis B, immune globulin and vaccine are given according to the worker's vaccination status and antibody titer. The single most tested phrase on the NHA exam regarding needle sticks is wash the area immediately with soap and water and report the incident. Memorize that exact wording, because it appears in answer choices deliberately designed to trip you up. Wash first, then report. Calling OSHA is never the first step in any scenario. Common pitfalls on exposure questions include answers that suggest squeezing the wound, applying a tourniquet to the arm, or calling OSHA before reporting internally. None of those are correct on this exam. Internal reporting through your supervisor and employee health is always first. OSHA recording happens later through the 300 log, if criteria are met. As we wrap up this detailed overview, remember that understanding these concepts is just the first step. The real mastery comes from applying them in realistic exam-style questions, which is where those free practice questions become invaluable. They are completely free. The link is in the description, and they are designed specifically for NHA CPT exam success. Let us take a moment to connect everything we covered today. We started with the federal framework, where OSHA enforces, NIOSH researches, and CDC recommends. Then we moved through accreditation standards from the Joint Commission, KELI-SI, and CAP, plus the ethics and HIPAA rules that govern your conduct. We then tackled quality control, WestGuard rules, and CLIA-wave testing. From there, we worked through the Bloodborne Pathogens standard, with its hierarchy of controls, hepatitis B vaccination requirement, and the strict sharps disposal rules. Finally, we covered biohazard spills, regulated waste, eye wash stations, the 1 to 10 bleach dilution, and the needle stick response protocol. Every single one of these topics is fair game on test day. You now have the foundation to walk into your exam with real confidence. Do not forget to grab those free practice questions from the link in the description. With the depth of knowledge you gain today plus targeted practice, you will be incredibly well prepared for your NHA certified phlebotomy technician exam. You have got this. Go pass that exam.